Assalamu alaikum. In this lecture, we shall go through some of the specific features of the Parotid Warthin's tumor that helps in establishing the diagnosis, like for example the bilaterality of the tumor, and also helps in guiding the selection of the optimal management plan. Wharton's tumor is termed adenolymphoma or papillary cystadenoma lymphomatosum. It's the second most common benign parotid tumor, accounting for about 20% of the benign parotid tumors, second only to pleomorphic adenomas. It affects the parotid gland almost exclusively. There is a strong male predominance. Historically, the male to female ratio was 5:1, but this is rapidly narrowing due to the changes in the smoking trends, more females picking up the habit of smoking. It affects more the elderly, and the peak incidence is in the 6th and the 7th decade. It can be bilateral in up to 10% of the cases and multifocal in up to 20%, and this is a unique feature among other benign salivary tumors. It has a very strong association with tobacco smoking, and it affects the black Afro-Caribbeans much less than it affects the other populations. There are two main theories for the origin of this tumor. The most accepted, the first is heterotropic salivary duct epithelium within an intraparotid lymph node or a periparotid lymph node. Some epithelium from the salivary ducts are enclosed within the lymph nodes within the parotid or very close to it. This is very similar to the origin of branchial cysts, for example, that arises from epithelial remnants enclosed within neck nodes. And this would explain why the tumor is so rare in the submandibular gland, because submandibular glands contain no intraglandular lymphoid tissue. There is increasing evidence to support this theory and that this is a true neoplasm, not a reactive lesion, based on finding of some DNA mutations in the mitochondria of the oncocyte cells, and also in the finding of monoclonal epithelium proliferation. The other theory is that oncocytic epithelial proliferate and is associated with a reactive lymphoid tissue. So you have two lines of cells, the oncocytes and the lymphoid stroma. And this is based on some studies that suggested a polyclonal origin for the epithelium rather than a monoclonal origin. But of course, this is challenged by further studies that suggest the clonal origin is associated with a fusion of an oncogene transformation. So this heterotropic salivary duct epithelium within intraparotid lymph nodes remains the most accepted theory. How does the tumor develop? It's known that it is very strongly associated with smoking. If someone smokes, he has an increased risk of developing this tumor, up to 8 to 15 times those who don't smoke. And it's also dose related. The more you smoke, the more likely you are going to develop this tumor in terms of the number of cigarettes or packs per unit time. It's likely due to salivary duct epithelium oncocytic metaplasia, formation of more mitochondria in these duct epithelium due to the chronic inflammatory stimulation. Tumor section would show an ovoid or spherical mass. And this mass is well circumscribed. It's usually between 2 and 4 centimeters and had variable number of cysts inside the lesion, inside the tumor itself. And these cysts can sometimes be clear or can contain a high protein fluid inside, or sometimes there may be also some hemorrhage in one of these cysts. In addition, there will be a shaggy epithelium and also solid areas with white nodules representing the lymphoid follicles. The fluid inside some of these cysts, particularly if they contain the high protein fluid or hemorrhage, would look dark in color, brown fluid, sometimes termed motor oil fluid. Microscopically, the tumor would show a biphasic tumor cells. The first is an epithelial component formed of a double layer of epithelium with oncocytic epithelium with high mitochondrial content. This epithelium could fold, infold, and form papillary projections inside the cysts, and these papillary projections is surrounded by lymphoid tissue. This is the second line of the cells that can sometimes, this lymphoid stroma can form germinal centers or could form reactive lymphoid tissue. So these are the two types of cells for this biphasic tumor. The histopathological features, in addition to the squamous oncocyte metaplasia, would include things like necrosis or even infarction in the tumor, plus signs of acute or chronic inflammation and fibrosis from the repeated inflammation of the lymphoid stroma. Sometimes this could form a granulomatous inflammatory reaction, and sometimes cholesterol granuloma could be identified in relation to the history of hemorrhage into the cystic spaces. Very rarely, in less than 1% of the cases, there will be signs of malignant changes. The typical biphasic tumor cells could be identified by immunohistochemistry. CK7 would identify is a mitochondrial marker for the epithelial line, and the lymphoid stroma could be identified as polyclones of beta and T cells, lymph cells. Fine needle aspiration cytology can be very useful if it is positive and shows specific features of the Wharthin's tumor in deciding on the line of management. Surgery may differ if the diagnosis is established. The accuracy of fine needle aspiration cytology generally in most large series would be somewhere between 80 and 90%. The specific cytological features of the Wharton's tumor are the oncocytic epithelial cells, pinkish cells with abundant granular cytoplasm full of mitochondria. There will also be signs of lymphoid background and the proteinaceous debris and some macrophages as well. Fine needle aspiration cytology can be helpful in differentiating whether a lesion in the parotid is due to a neoplasm or a non-neoplastic process like a reactive or a chronic inflammatory or a granuloma. It can distinguish between a benign or a malignant nature of the neoplasm, and if the cell of origin for the neoplasm is identified clearly, it can establish a specific diagnosis of a particular type of a tumor. This can be very helpful in avoiding surgery in a significant number of patients, and also helpful in the patient counseling perioperatively and in choosing the right surgical technique or right parotid resection for a specific tumor. The problem is that frequently the sampling process may be inadequate, requiring the process to be repeated, sometimes several times, and this would prolong the course of the diagnostic workup. On the other hand, a needle core biopsy would have a higher accuracy than a fine needle aspiration. The accuracy may reach 100% for insensitivity and 92% for specificity. It's more invasive though, but there is no strong evidence that there is a greater risk of tumor spillage and maybe a very small chance of more facial nerve irritation. The core biopsy can be used as a first line, or it can be used as second line after a fine needle aspiration failure to obtain adequate samples or when malignancy is suspected. The use of ultrasound during the process of the fine needle aspiration or the needle core biopsy would increase the chance of getting an adequate sample, and it will also provide some useful information from the scan itself. Wharton's tumor can present in several ways. The most common presentation would be a slowly growing mass in the tail of the parotid. This mass is painless and it can be fluctuant due to the cystic nature of the tumor. It affects more the elderly in the 6th or the 7th decade, has a more male preponderance, and the patients are usually smokers. It can be bilateral in 10% of the cases or can be multicentric. The other form of presentation is an acute presentation where the patient presents with a painful mass, sometimes with signs of acute inflammation like redness and hotness. This may be associated with a rapid expansion in the size of the cyst, possibly caused by the inflammation. It can also present in the same way by a painful sudden pain and a swelling that may increase in size due to infarction in the tumor rather than an infection. The third way of presentation would be picking the tumor as an incidental finding in scans done for other reasons in the head and neck, including PET scans or MRI scans. The red flags are a rapid enlargement in the size of the mass. This would usually points to either infarction or an infection in the lesion. Pain is also not a usual feature, but can be caused by either the infection or the infarction or a cyst rupture and some hemorrhage inside the tumor. Facial nerve weakness is not a feature, it's rare and would usually suggest an alternative diagnosis, like for example a tumor. Tumors can very rarely develop in a patient who had a Wharton's tumor. This may be either an adenocarcinoma or a squamous cell or even undifferentiated carcinoma. But there are few reports about this, but it's not clear whether this represents a true malignant transformation as such, or represent a dual pathology, or even an erroneous pathology, erroneous initial diagnosis. Imaging would be useful in establishing the diagnosis. The ultrasound scans are usually the first line, and they can be used while there is a sampling by fine needle aspiration or needle core biopsy. They would have some characteristic findings. The lesion would be usually superficial and well-defined lesion that it is hypoechoic in general, but there will be other area of heterogeneous echogenicity. The lesion may be septated. There may be obvious septi inside the lesion around the cysts, and these septi can be hypervascular on Doppler examination. The other areas of the tumor would be cystic. MRI scans are the gold standard in establishing the diagnosis of a Wharton's tumor. The T1 weighted images would show a well circumscribed lesion that is a heterogeneous signal due to a mixture of cystic spaces and solid components of the tumor. The signal may be low or intermediate, and there will be areas of high signal representing the areas of the hemorrhage or the proteinaceous material inside the cysts of the tumor. The hypointense area can be also formed as a rim around the tumor and is indicative of chronic hemosiderin and blood degradation products. If a lesion is found bilaterally or if it is multifocal, this will also add more weight to establishing the diagnosis. The T2 weighted MRI image is helpful in differentiating a Wharthin's tumor from a pleomorphic adenoma. The signal in the Wharthin's tumor is lower than the signal in the pleomorphic adenoma in the T2 weighted images. When using the T2 weighted fat saturation, there will be a hyper-intense signal that is also heterogeneous. Enhancement is usually poor in Wharton's tumor, apart from the septi inside the tumor that are usually very vascularized. The diffusion-weighted imaging for the MRI scans of Wharton's tumor would show a restricted diffusion. The apparent diffusion coefficient, the ADC, of the Wharton's tumor would also be much lower than that of the pleomorphic adenomas, for example. The pleomorphic adenomas are usually have higher ADC compared to that of a Wharton's tumor. CT scans are not the preferred imaging modalities for Wharton's tumor or for parotid tumors in general, but they sometimes can be indicated if the MRI scans cannot be obtained or are contraindicated. The CT scans would show a well-circumscribed mass in the lower pole of the parotid, which is cystic in part and solid in others, and the lesion would be enhanced between mild and moderate enhancement. The other imaging features of the Wharton's tumor is that the tumor itself is able to concentrate sodium pertignate very highly, and this is one of the features in the scans that are suggestive of a Wharton's tumor. Also, on PET CT scans, the Wharton's tumor would be very intense, and this may be a common cause for false positive malignancy suspicion in parotid lesion. A very intense lesion on a PET CT scan may well be a Wharton's tumor. The Wharton's tumor would need to be differentiated between other parotid lesions that have a heterogeneous consistency with a mix of solid and cystic areas, and also parotid lesions that have a dual cellularity, epithelial cells and lymphoid cells. These include the pleomorphic adenoma, the parotid cysts, low-grade mucoepidermoid carcinoma, and a metastatic lymph node in the parotid or a parotid lymphoma. Prognosis is excellent. The rate for malignant transformation is estimated at less than 1%. It's very rare, and there will be rare forms of tumor like carcinoma ex Wharton's or a lymphoma. Recurrences after surgery are also very rare. A true recurrence is rare. When it happens, it may represent a new lesion in a multifocal disease. The management strategies include two major options: either observation with conservative treatment sometimes, or parotid surgery. The first line, the observation, is increasingly accepted. The tumor often grows very slowly or not at all. Malignant transformation rate is very rare, and observation may be appropriate if the lesion is asymptomatic in an elderly or a patient who have several comorbidities, and when the cytological features and the imaging confirmed a classic Wharton's tumor. If the patient also asks for an observation rather than surgery, this should be the case. Occasionally, conservative treatment of acute inflammatory process in a Wharton tumor may be required. The second line is parotid surgery. Surgical management may be indicated if there is diagnostic uncertainty about the nature of the tumor, if the lesion is symptomatic and causing pain or unsightly swelling, or if the patient is anxious about it, or if there is rapid growth of the lesion or any other complications. The main worry for surgery is the risk to the facial nerve. The nerve is usually not affected. Temporary weakness after surgery is in the area of 10%, and permanent palsy will be less than 2%. In addition to simple inoculation, which ran out of favor, the other types of surgical resections for this type of benign tumor include the extracapsular tumor resection, in which the facial nerve trunk is identified together with its major divisions. The tumor itself is resected just outside its capsule with a tiny cuff of normal parotid tissue, leaving behind most of the parotid gland. The superficial parotidectomy operation comprise a formal identification and dissection of the facial nerve and all its major branches, and the resection of all the parotid glands superficial to the level of the facial nerve, including the tumor, or if the tumor lies deep to the facial nerve level, a superficial parotidectomy is carried out first, followed by resection of the deeper part of the gland, deeper to the facial nerve and its branches, together with the tumor. Out of the three surgical options for excision of the Wharthin's tumor, the extracapsular dissection is the most conservative. It may be indicated in a small tumor, less than 3 centimeters, superficial lobe, and well circumscribed, and not affecting the facial nerve directly, and if availability of an experienced surgeon is there. The advantage, of course, is a lower risk to facial nerve injury, particularly transient or temporary facial nerve injury, and less morbidities in the form of Ray's syndrome and other minor complications of the parotid surgery. The second operation, the superficial parotidectomy, need not be a complete superficial lobe resection. Resection of half of the superficial lobe, usually the inferior half, what is termed as a hemi or a partial superficial parotidectomy, is increasingly the preferred surgical option for the Wharthin's tumor. It's indicated in if the tumor is a bit larger, but still in the superficial lobe, and when the tumor is in close proximity to the facial nerve branches, and when there is some limited mobility of the tumor, possibly due to previous infective episodes, and when there is a bit of uncertainty about the integrity of the capsule. The advantage is that it gives an excellent exposure of the facial nerve and all its branches, and allows resection of the tumor together with a larger cuff of parotid tissue in case the capsule is attached to the parotid by fibrous scar from repeated inflammation. The third option is not very common. This is a partial or a total parotidectomy if the tumor is affecting the deep lobe, or if it is a giant tumor, or if there are multifocal tumors affecting several areas of the parotid, or if it is a recurrent tumor. In that case, you may need to do a total parotidectomy or a partial total parotidectomy. How much is the safety margin? The resected normal tissue of the parotid gland around the tumor? Not much at all. in the extracapsular dissection or in the hemi-superficial parotidectomy, removing half of the superficial lobe. The main thing is to remove the tumor within its capsule. Even if there is a minor breach of the capsule, the risk of recurrence is very low. So a tiny amount, like 1 or 2 millimeters of parotid tissue cuff around the tumor will be enough. And even if this is not available in areas where the tumor is in close proximity to the facial nerve, extracapsular dissection is enough. So to sum up, if a parotid lesion in a smoker who is elderly and is male, and the lesion is in the tail of the parotid, think Wharthin's tumor. If it is bilateral or multifocal, that would add more weight to establishing a specific diagnosis of Wharthin's. A low T2 signal on MRI scan would also help in establishing the diagnosis and differentiating this from a pleomorphic adenoma, which is by far more commoner. Observation and conservative management of the odd inflammatory episode is acceptable in selected patients, and surgery is curative with minimal recurrence and few morbidities. By this, we come to the end of this lecture on Wharthin's tumor of the parotid, the specific diagnostic and surgical features. Assalamu alaikum.